We tell patients bronchoscopic biopsy is safe, but are we completely honest about the risk of spreading cancer? There are documented cases, real cases, where tumor cells appear exactly along the biopsy tract after bronchoscopy. So how real is this risk, and should it change what we do? Today, we'll break down the actual evidence behind tumor seeding and then move into two other studies that may quietly reshape your practice, one questioning CPET before lung surgery, and another highlighting a blind spot in rheumatoid arthritis care. Welcome back to This Week in Pulmonary and Critical Care Medicine. This week is a mix of uncomfortable questions and practical clarity. Let's start with the one that makes people uneasy.
Tumor seeding is not hypothetical. In percutaneous lung biopsy, it's measurable. Large data sets show seeding rates between 0.6% and 2.7%, meaning up to 1 in 40 patients may experience tract-related tumor implantation. That's the benchmark most clinicians have in mind when they worry about this complication. Now contrast that with bronchoscopic biopsy. Published in Respiratory Medicine, across a systematic review covering 25 years of literature and 58 publications, only 4 well-documented cases of tumor seeding after transbronchial biopsy were identified. 4 cases globally. And the timing is consistent. In those cases, seeding appeared between 1 week and 4 months after the procedure, typically as a new lesion at the puncture site. So the absolute signal is not just low, it's almost absent. Now here's where you need to be careful. You don't have a denominator. You don't know how many total bronchoscopies were performed over that time period, so you can't calculate a precise incidence. But even if you assume massive underreporting, the gap between 4 cases and 0.6 to 2.7% is too large to ignore. There's also a mechanistic explanation. With transthoracic biopsy, you traverse the pleura and create a clear tract where tumor cells can implant. With bronchoscopy, you're working within airway structures, with shorter and less defined tissue disruption. The biology is simply less favorable for implantation. Another key detail from the review: most reported seeding cases involved EBUS tBNA, often combined with more aggressive sampling techniques like cryobiopsy or intranodal forceps biopsy. So even within bronchoscopy, this is not a uniform risk. Now let's correct a common clinical error. Post-procedure tumor growth near a biopsy site is often assumed to be seeding. But the criteria for true seeding are strict: a new lesion at the biopsy tract, rapid focal growth, histologic confirmation, and temporal association. Most cases don't meet that bar. What you're usually seeing is natural tumor progression. If you overcall seeding, you inflate perceived risk, and that leads to worse decisions, avoiding bronchoscopic biopsy, delaying diagnosis, or defaulting to more invasive approaches. So what does this mean in practice? The risk of tumor seeding with bronchoscopic biopsy is orders of magnitude lower than with percutaneous biopsy. It exists, but it is so rare that it should not influence your choice of diagnostic approach in routine clinical practice. We've been using cardiopulmonary exercise testing for decades to stratify surgical risk, largely based on peak VO2 thresholds. But the data supporting that approach comes from an era with higher surgical morbidity. Published in Thorax, in this study of 497 patients undergoing lung resection, postoperative complications were still common. Pulmonary complications in 14% of patients, cardiovascular complications in 18%. So prediction matters. The investigators compared 2 models, one using standard clinical data and pulmonary function tests, the other adding cardiopulmonary exercise testing parameters. The expectation is that cardiopulmonary exercise testing would improve prediction. It didn't. For pulmonary complications, model performance stayed in the range of an area under the curve of 0.72 to 0.78,
with no statistically significant improvement when cardiopulmonary exercise testing was added. For cardiovascular complications, the area under the curve ranged from 0.65 to 0.73, again with no improvement, p equals 0.96. And importantly, this held true across subgroups, patients meeting ACCP criteria and patients meeting ERS-ESTS criteria. So even in higher risk patients, cardiopulmonary exercise testing did not meaningfully improve prediction. What does that mean clinically? It means that adding cardiopulmonary exercise testing is not improving your ability to identify who will develop complications, not slightly, not marginally, not at all. That's a strong statement. Now, there are nuances. Cardiopulmonary exercise testing still provides physiological insight, and there may be individual cases where it influences decision-making. But as a routine screening tool, its incremental value appears negligible. The likely explanation is that modern outcomes are driven by multiple factors: surgical technique, perioperative care, patient selection, and those may already be captured by simpler clinical variables. This would suggest that routine cardiopulmonary exercise testing before lung resection should be reconsidered. It should shift from a default test to a selective tool used in complex or uncertain cases. We tend to diagnose ILD in rheumatoid arthritis when patients become symptomatic. But by that point, the disease is already established. Published in Chest, this review highlights something we're probably under-recognizing. Subclinical ILD represents an earlier phase, radiographic abnormalities on CT in patients with no symptoms and often normal pulmonary function tests, and it's not rare. Prospective data suggest that around 25% of patients with rheumatoid arthritis have subclinical ILD. That's 1 in 4 patients. Now let's follow what happens to these patients. In one cohort, 12 out of 21 patients, about 57%, showed radiographic progression over 1.5 years. In another study, 6 out of 7 patients, 86%, progressed within 1 year. So progression is not hypothetical, it's common. But here's the key uncertainty. Not all patients with radiographic progression develop clinically significant ILD, and we don't have reliable predictors to distinguish who will progress in a meaningful way. We do know the risk profile: older age, male sex, smoking, higher inflammatory markers, and autoantibody positivity all increase the likelihood of subclinical disease. But that's population-level risk, not individual prediction. There's also a signal for worse outcomes. Patients with RA-associated ILD have a hazard ratio of 2.42 for mortality compared to those without ILD. And subclinical disease may contribute to that, although the data aren't cleanly separated. Now let's address a misconception. Early detection automatically improves outcomes. That's only true if early intervention changes the disease course. Right now, we don't know that. So you're left with a dilemma. If you screen aggressively, you identify disease you may not know how to manage. If you don't screen, you may miss the window for intervention. That tension defines this space. So what does that mean? You should recognize that subclinical ILD is common and clinically relevant, especially in high-risk RA patients. But routine screening and early treatment strategies are not yet defined and should be approached cautiously. If you're still here, you're exactly the kind of clinician this channel is built for. Because staying updated right now isn't optional. It's the difference between practicing based on habit and practicing based on what's actually true today. This week alone, a complication that sounds dangerous turns out to be almost negligible. A test we still rely on may not be adding value, and a disease we rarely look for may already be present in 1 out of 4 patients. That's the gap this series is trying to close. If this saved you time or changed how you think about even one of these topics, subscribe, and more importantly, share it with someone in your group. Because the reality is, most people are not reading these papers, and they're still practicing anyway. Until next week, this is Dr. Aladdin Sagar, signing off.